This video is essentially the continuation of the previous one. In the previous video, we have discussed in detail with regards to the basics of the DK and HHS and how you're going to diagnose in your clinical practice. In this particular video, we're going to have a deep dive on the management principles of DK and HHS and why these disorders are difficult to manage because of the intrinsic challenging nature of the disorders itself and the complications they are going to pose once you start the treatment. And you also have to understand the fact that once you know the treatment of DK, it's easier to understand the treatment of HHS also because both follow a very similar line of management. Because you know the pathophysiology better, now whatever terms I'm going to use is going to be much easier for you. Let us start with the overview of management and let us begin with the problems that these DK patients are going to face. The first problem is going to be obviously the dehydration and the volume loss. At the same time, they're going to have a lot of sodium loss. Often it is overestimated, but still they have a huge amount of sodium loss that is happening. And the third problem that these patients are going to face is the hyperglycemia itself, which is going to pose its own problems like hyperosmolality and encephalopathy. As far as DK is concerned, the major problem that happens in these patients is the ketoacidosis. That is due to insulin deficiency. And that is what is bringing the patient to the hospital in a patient who is suffering from a diabetic ketoacidosis. And at the same time, we should not forget about the potassium, where the potassium loss is also substantial in patients with DK and HHS. And at the same time, you should not forget about the other electrolytes like bicarbonate, which is severely affected in DK patients, and phosphate and magnesium losses, which also has to be taken care, especially when it is very severe. So the first therapy that I'm going to use is going to be the fluids. So fluids can correct the dehydration, fluids can correct the sodium loss, and fluids itself to an extent can correct the hyperglycemia also. So that's what the arrow is showing here. And once you have given fluids, after 30 to 60 minutes, I'm going to start with insulin therapy. Remember the fact insulin is the most important therapy as far as DK is concerned. Remember, fluids are the first line management. I'm not denying that fact, but insulin is the most important treatment as far as DK is concerned because the basic reason for these patients coming to the hospital is ketoacidosis, and the basic reason for these patients developing ketoacidosis is the insulin deficiency. And if you do not give insulin, they will not resolve from the ketoacidosis and you will not be able to discharge the patients from the ward or from the ICU. Finally, you have to give other electrolyte supplements as well if it is warranted. We'll be discussing about that as well. Electrolytes, in particular, you have to take care of the potassium. So that is the reason why DK treatment in short or HHS treatment in short can be written as FLIP therapy, where the FL stands for the fluids, which is the first line treatment, then followed by the insulin and potassium. The order of insulin and potassium can be changed depending on the serum potassium levels, but the next two therapies are insulin and potassium replacement for the patient. So the first therapy is going to be the fluids, which is going to correct the dehydration, sodium loss, as well as hyperglycemia to an extent. So first reason for giving the fluid is volume replacement to correct the hypovolemia, and obviously they're going to correct the sodium as well. At the same time, they're going to reduce the blood glucose as well. So many students do ask how fluids are able to reduce the blood glucose. Well, it's because of two reasons. One, because of the dilution effect of the fluids. The blood glucose in these patients are relatively high, partly because of one reason, that the blood will be concentrated so much. There will be hemo concentration because of the loss of the fluids in the urine. So by diluting, you will be reducing the concentration of glucose to a certain extent. And second most important reason is the fact that volume expansion will definitely reduce the counter-regulatory hormones. And we know hypovolemia will increase the levels of counter-regulatory hormones, and these counter-regulatory hormones coupled with insulin deficiency is one of the main reasons for the development of severe hyperglycemia in these patients. So once you give a good volume expansion, these counter-regulatory hormones levels will go down, resulting in reduction in the blood glucose. And how much blood glucose can be reduced? Only with fluids alone that are going to give for the first 30 minutes to 60 minutes, that itself can reduce the blood glucose to by 150 to 200 milligrams per deciliter in the first hour. So the first hour is dedicated to fluids. Usually, it is prudent to start insulin after a period of 30 to 60 minutes. So in the first hour, usually we start with fluid and fluid resuscitation. How to give fluids, we'll be discussing in some time. But once that 30 to 60 minutes period is over, which is spent on very valuable fluid resuscitation, then after 30 to 60 minutes, you are going to start with insulin therapy. And insulin therapy is really, really important. So what insulin therapy is going to do? What are the effects of giving insulin? Number one, obviously they are going to reduce the blood glucose. There's no doubt about that, by suppressing the gluconeogenesis, at the same time by pushing the glucose into the cells. It's going to increase the cellular uptake of glucose by increasing the translocation of the GLUT4 transporters. Second point is the fact that they are going to reduce the ketoacidosis, and over time they are going to resolve the ketoacidosis that is happening in the patient. But remember the fact, ketoacidosis will not be resolved unless and until you give adequate amount of insulin. The most common reason for a non-resolving diabetic ketoacidosis is inadequate insulin therapy. So that's the most important treatment as far as DK is concerned. So obviously insulin is going to inhibit the hormone-sensitive lipase enzyme, which is going to suppress the lipolysis. At the same time, they can reduce the production of ketone bodies. It is anti-ketotic in nature, we know that. So that's how they resolve the ketoacidosis. And number three, insulin is associated with one important problem, that is worsening of hypokalemia. We know why it worsens hypokalemia. The serum potassium may be normal, doesn't matter, but still giving insulin will produce more hypokalemia, especially in DK patients, because insulin itself will push the potassium into the cell. We saw that already. And at the same time, it will correct the acidosis that will result in more movement of potassium into the cell, resulting in more severe hypokalemia. That is the reason why you have to take care of the electrolytes, especially potassium, and you have to be very cautious about the potassium replacement. As I told you before, if the potassium levels are higher, you give insulin alone. If the potassium levels are in the normal range, you give insulin and potassium together. If the potassium levels are low, in that setting, never start insulin infusion. In that setting, start with potassium replacement first, make the serum potassium normal, then go for the insulin infusion. Obviously, we know once we start with the insulin infusion, your blood glucose is going to fall, and the target blood glucose fall is approximately 50 to 75 milligrams per deciliter per hour. Once you start with the fluids itself, in the first hour itself, your blood glucose is going to fall by approximately 150 to 200. But once you start insulin, you have to be a little bit guarded, and you have to reduce the blood glucose by approximately 50 to 75 milligrams per deciliter per hour. And you have to know the timeline of resolution of problems in patients suffering from DKA, which is very important, because you have to understand one crucial point, that the insulin infusion should not be stopped despite the blood glucose becoming normal. So that's why I want to tell this timeline. So the point number one is the fact that the first thing to resolve in a patient suffering from DKA or even from HHS is the hyperglycemia. That's the first thing to resolve. Usually it resolves within 4 to 8 hours, depending on the severity of DKA and the amount of counter-regulatory hormones that are circulating in the system. And second is going to be the ketosis, which typically resolves by 10 to 12 hours. And the final thing to resolve is going to be the acidosis, which typically takes around 14 to 18 hours to resolve, which means the first thing to resolve is the blood glucose, and the final last thing to resolve is the acidosis. But please understand the fact, in a good setting, in a proper treated settings, your DKA will resolve completely within 24 hours. Clear? So why this timeline is important? Because you know the hyperglycemia is the first to resolve, which means the blood glucose will become normal very rapidly, very fast, within 4 to 8 hours. But this is not the indication to stop the insulin infusion, and it is one of the very commonly done mistakes in the ICU as well as by the newcomer resident. Why? Because once the blood glucose becomes maybe 200 or 180 or 150, he immediately stops the insulin infusion, because thinking that further insulin infusion will result in hypoglycemia. But it should not be done. And if you stop the insulin infusion without the ketosis and acidosis getting resolved, you are going to result in persistent ketoacidosis, and the patient will be persistently symptomatic, and you will not be able to discharge the patient back at all. So do not stop the insulin infusion unless and until the ketoacidosis is resolved. Now you'll be asking the question, if I continue with insulin infusion, my blood glucose will fall and I'll end up with a hypoglycemia. So that is the reason, once the blood glucose becomes normal, you add dextrose solutions, but do not stop the insulin infusion. So you have to continue insulin infusion in this setting, despite the blood glucose becoming normal. So to prevent hypoglycemia, I'm going to give dextrose infusion. At the same time, if I ask one indication to stop insulin infusion, the only indication to stop insulin infusion is resolution of ketoacidosis. So stop infusion only if ketoacidosis is resolved. Otherwise, you should not stop insulin infusion. Clear? I think this is the most important point of the entire lecture. So premature stopping of the insulin infusion and inadequate insulin therapy is the most common reason for an unresolved DKA, even after 24 hours. Clear? Fine. So let us dissect each and every treatment in detail. The first treatment I'm going to dissect is the fluids. It's very difficult to understand fluid therapy, and I'll try to make it in a much simpler way, but yes, this is the protocol that we follow, which I'm going to tell in some time. So how you are going to give fluid therapy? First, understand the fact you have to put 2 peripheral cannulas, which are basically wide bore, because you're going to give a substantial amount of fluids and different fluids at different rates, so it's a little complicated. So get 2 peripheral IV cannulas done. But try to avoid central lines as much as possible, because central lines in DK is associated with higher risk of thrombosis because of the hemo concentration they have already because of the volume loss, and at the same time there is increased risk of central associated bloodstream infections as well. So try to avoid central lines in patients with DK and HHS. Try to give peripheral cannulas and try to put 2 peripheral cannulas. That's it. So giving a fluid is based on the assessment of severity. That's very, very important. There are 2 guidelines that will tell you the severity. One is the IPSAD guidelines, that is based on the clinical assessment. So usually this IPSAD guidelines is used only for children. Adults, it becomes even more difficult, and we don't have any particular guideline in adults. You go by the other guideline which I'm going to tell. So clinical assessment is valid only for children in this perspective, not for the adults. So you can categorize as mild decay, you can categorize as moderate decay, and finally you can tell it's a severe decay based on the clinical assessment itself. The first one is the level of dehydration that these patients are going to have. As I told you before, it's less than 5% in mild, 5 to 10% in moderate, and more than 10% in the setting of severe decay. That is the level of dehydration that these patients are going to have. Next is the oral mucosa, and you're going to see the oral cavity. So oral cavity is supposedly normal in patients suffering from mild decay. It will be dry in patients suffering from moderate decay, and it will be very, very dry in patients suffering from a severe decay. And you're going to see the skin turgor. The skin turgor is supposed to be normal in patients who are suffering from mild decay, slightly decreased in patients who are suffering from moderate decay, and significantly decreased in patients who are suffering from severe decay. And whether the peripheries will be warm or cold is also very important. So generally, mild decay and moderate decay tends to have a warm periphery, whereas severe decay patients tend to have a cold periphery. And we can also assess the capillary refill time, which is very important in children, wherein mild and moderate decay tends to be less than 2 seconds, whereas in severe decay tends to be more than 2 seconds. There are some guidelines which give mild decay means less than 1.5 seconds, moderate decay means 1.5 to 2.5 seconds, and severe decay means more than 2.5 seconds. But these are nothing but just to play with the numbers, that's all. But apart from that, the idea is taken. And what about the pulses? The peripheral pulses will be normal in patients who are suffering from a mild decay and a moderate decay, and it will be feeble and thready in patients who are suffering from a severe decay due to severe volume loss. Blood pressure, once again, it's supposed to be normal in patients who are suffering from mild and moderate decay, and it can be decreased in patients who are suffering from severe decay. Please understand the fact that shock is extremely uncommon in patients with decay because of the too much excess of counterregulatory hormones and increased intravascular volume because of the fluid that is pulled out of the intracellular compartment. And shock is very rare. If there is a shock in decay patient, think about sepsis, that is underlying disorder in the patient, or the patient could have a cerebral edema, or the patient will be having a very severe decay. Shock is uncommon, especially in children. And finally, we have the urine output based criteria also, where urine output we are going to give in mLs per kilogram per hour. So in a mild decay, it will be more than 1 ml per kilogram per hour. In a moderate decay, it will be 0.5 to 1 ml per kilogram per hour. Whereas in severe decay, it will be less than 0.5 ml per kilogram per hour, which forms the definition of oliguria. So if the patient is oliguric, that indicates a severe decay. So this is how you clinically assess the severity of decay according to the IPSCD guidelines. But we have another guideline, BPSCD guidelines, which is totally based on laboratory profile, especially the pH and the bicarbonate. So which I mentioned already, just for understanding sake, I'm telling once again. Mild decay according to the BPSCD guidelines is defined as pH in the range of 7.2 to 7.3. Obviously, pH more than 7.3 will not be a decay, and bicarbonate in the range of 10 to 15. And moderate decay according to BPSCD means pH is in the range of 7.1 to 7.2 and bicarbonate in the range of 5 to 10. And severe decay means pH less than 7.1 or bicarbonate less than 5. So this is going to be severe decay. And this assessment of severity of decay is going to form the basic step 1 of our fluid therapy. And please understand the fact that we are going to have 6-stepped approach, and at the same time this fluid therapy will be initiated after this dehydration assessment only if the cardiac function is supposedly normal. Suppose the cardiac function is abnormal and the patient is having low ejection fraction or a gross volume overload state, and I'm not going to give the fluid bolus or any fluid resuscitation, and even sometimes I will defer the fluids itself in the first place. So all the calculations I'm going to tell from now on is based on the assumption that the patient's cardiac function is normal, which is usually the case. So after step 1, dehydration assessment, I am moving to the step 2 to calculate the fluid deficit, calculate the deficit in this individual. Let us take a standard patient who's an 80 kilogram old man coming with a mild to moderate decay, and obviously he will be having an estimated fluid deficit of 5 to 10%. I'm going to take a lower limit, that is 5%, because in decay, as I told you before, the fluid deficit assessed clinically is often overestimated. So I'm going to take a lower limit, 5%. So in this setting, 80 multiplied with 5% will give the value of 4 liters, and that is going to be the fluid deficit in our patient. And I'm going to replace the 4 liters. So I'm going to replace, let us go to the step 3. In the step 3, I'll be resuscitating the patient because they'll be having a gross volume loss and a hypovolemic state. So first I have to resuscitate the individual. And the fluid of choice for resuscitation, we know very well, it is always isotonic saline, that is 0.9% NaCl. So the question is, what is the amount of fluid that you have to give for resuscitation, and what is the time period over which the resuscitation fluid has to be given? And the third question is, how many boluses that you are going to give? Because you are going to resuscitate in the form of giving fluid boluses. So how many bolus you have to give? That is also a third question that has to be answered. So per bolus, the amount of fluid will be determined by the age of the patient. Suppose if it's an adult patient, I'm going to use a fluid bolus of 15 to 20 ml per kilogram. So let us take a prototypical patient who is 80 kilogram in weight. For an 80 kilogram patient with a decay, I'll be giving a fluid bolus of 1.5 liters. Fine. If it's a child, I'll be giving a fluid bolus that is dependent on the severe decay. If it's a mild decay, I'll be giving a fluid bolus of 10 ml per kilogram per bolus. And if it's a moderate to severe decay, I'll be giving a fluid bolus of 20 ml per kilogram. Time over which the bolus has to be distributed is 1 hour. Some guidelines till 30 minutes also, but that kind of very over-aggressive fluid is also not needed. In our institution, we often follow 1 hour, which is the standard. So 1 hour each bolus. So how many bolus have to be given? That depends on the clinical status of the patient. If the patient is stable, I'm going to give only a single bolus. If the patient is unstable, I can give a rebolus. I can rebolus one more time. I can give 2 boluses maximum. That is the idea. And try to avoid more than 2 boluses. That's very important because even after 2 boluses, if the patient is still hypotensive, strongly consider the possibility of a septic shock and you have to start with vasopressin, like Norepinephrine or vasopressin. Now you know how to resuscitate in the form of bolus, how much amount each bolus should be given, and how much time each bolus has to be distributed over, and at the same time, how many bolus I can give. So all these questions have been answered. Now moving on to the step 4. Once I have resuscitated the patient, next step is to go for the maintenance phase. But during maintenance phase, you have to select a fluid. Resuscitation always isotonic saline, but in maintenance phase, there is one problem. We have to select the particular fluid, and that should be based on a fact called corrected serum sodium. So that is the step 4. I'm going to find out the corrected serum sodium. We know the formula for corrected serum sodium, which is nothing but the actual measured sodium plus the glucose value minus 100 divided by 100 multiplied by 2. So usually once you do this corrected sodium, that is the time where your insulin infusion will start, because the first phase is always fluid bolus, then only your insulin infusion will start. At the same time, simultaneously your maintenance infusions also will start. So suppose if the corrected sodium is less, that is less than 136, which means the patient is definitely still hypovolemic, and in that setting, I'll be continuing with the isotonic saline. Suppose if the corrected sodium is normal or increased, the patient is relatively hypernatremic in this stage, so I have to give a half normal saline in this setting. The details of which I have already described in the previous chapter in detail. So go back to the previous chapter if you don't understand this. So once I have selected my fluid of choice based on the corrected sodium, now I can enter the step 5, which is nothing but the maintenance phase. So during the maintenance phase, there are 2 things you have to address, because I have given only 1.5 liters out of 4 liters in the fluid resuscitation phase, which means remaining 2.5 liters of deficit I have not addressed. So during this phase, I have to give the remaining deficit that is there in the body, plus at the same time, I have to give fluids that is needed for my day-to-day bodily functions. So that is what we refer to as a maintenance fluid. Simply I can write as MF. So both has to be addressed during this step. You know the deficit already. So remaining deficit in our standard example is 2.5 liters. From the beginning we are seeing, because 1.5 we have already given out of 4 liters. So remaining is 2.5. We know that remaining deficit in all the patients. But how will you know how much maintenance fluid to give? So this is dependent on, again, whether the patient of interest is an adult patient or a child. If it's an adult, usually you are going to give maintenance fluid by a simple formula, that is 60 ml per hour, that is for urine output, plus you're going to take the weight of the patient minus 20 ml per hour. So let us take our prototypical example, standard example, 80 kilogram man. So here you will be giving 60 ml per hour plus weight is 60 minus 20 is another 60 ml per hour, that is roughly equivalent to 120 ml per hour. So in our example, the maintenance fluid is roughly equivalent to 120 ml per hour. Along with the 2.5 liters deficit, I have to give this maintenance fluid also. And next, in children, what I'm going to give is by calculating something called holiday cigar formula. So there are 2 sets of guidelines are there. For example, IPSAD guidelines tells that you can give maintenance fluid as per the famous holiday cigar equation or holiday cigar formula. What holiday cigar formula tells? So in a child, for the first 10 kilogram, the amount of fluid that is recommended is 100 ml per kilogram per day, which will be roughly equivalent to 4 ml per kilogram per hour. So this is nothing but a hourly calculation, which is derived from the per day calculation. For the next 10 kilogram, you have to add, not just you have to give for the entire 20, you have to add 50 ml per kilogram per day, which will be roughly translating to 2 ml per kilogram per hour. After 20 kilogram, for each kilogram, you have to give 20 ml per kilogram per day, and you have to add this to the already calculated fluid, 20 ml per kilogram per hour per day, which will be roughly equivalent to 1 ml per kilogram per hour. So let us calculate. So let us assume a child who is weighing 24 kilogram, you want to start with maintenance fluid. So now for the first 10 kilogram, and I'm going to give 100 ml per kilogram per day, so it will be roughly equivalent to 1000 ml. for the next 10 kilogram, so I know I have to give 50 ml per kilogram per day, so I'll be giving 500 ml. So next 10 kilogram, 50 ml per kilogram. And for the remaining 4 kilogram, because the child is weighing 24 kilogram, I'll be adding 20 ml per each kilogram. So I'll be adding another 80 ml, so which will complete the calculation, that is 1580 ml, which should be distributed over a period of 24 hours in an entire day. So this is the maintenance fluid, not the calculation along with the deficit, maintenance fluid alone. But there are some special problems that you're going to face. In the sense, if the child is having a fever, in this setting, I have to give extra fluid because there will be more insensible water loss. So I have to add 10% extra fluid to the maintenance regime for every 1 degree Celsius rise in the body temperature. For example, if the child is having a fever of 39 degrees Celsius, which is 2 degrees Celsius higher than the normal body temperature of 37 degrees Celsius, I should be adding 20%, that is 158 of 20% is 316 ml I'll be adding. So the final calculation will be 1896 ml per day. So if the child is having fever of 39 degrees Celsius. And at the same time, you have to be a little careful for heavier children who are little obese. Those are having more than 30 kilogram. It's better to avoid holiday cigar formula for these individuals. And it's better to use body surface area based calculation, which tells you it's better to use maintenance fluid of 1600 ml per meter square per day in these children. But our BPSCD guidelines are very conservative. They are telling giving this much amount of fluid is detrimental to the child's health, and especially the risk of development of cerebral edema is more. So they believe maximum fluid in a child with DKA should be 40 ml per hour only, and it should not exceed beyond this limit. So that is what the BPSCD guidelines are telling. Again, it depends what you follow, but BPSCD guidelines are more conservative in their approach. So how you are going to give this fluid during the maintenance phase? You have two things. One, you have to correct the remaining deficit. At the same time, you have to give the maintenance fluid as well. So usually we give it in the form of phased replacement. So what do you mean by phased replacements? You have phase 1, which goes for around 12 hours, and a second phase replacement, which goes for 24 hours. So first 12 hours, you will give first phase replacement, and the next 24 hours, you're going to give second phase replacement. In both the phases, you are going to take the remaining deficit and you have to split by 2, and 50% of the remaining deficit plus along with the maintenance fluid you have calculated will be given during this time over a period of 12 hours. And similarly, in phase 2, 50% of the remaining deficit along with the maintenance fluid will be infused during this phase. So which we'll be discussing in the form of an example in some time. So once you have given this, you also have to be aware of the step 6, that is the dextrose. Because as I told you, once you are starting with the maintenance fluid regime, you will be starting insulin infusion as well, because the resuscitation is over, and once the initial fluid bolus is over, you will be starting with the insulin infusion. So at one point, the glucose values will fall, definitely because of insulin. And at the same time, you cannot discontinue the infusion because the ketoacidosis will still be going on. So it's a tricky situation. I told you, do not stop the insulin infusion, but instead, if the CBG value falls below a critical level, start with dextrose infusions to prevent further hypoglycemia and further fall in the glucose. So what is the target CBG value that you have to maintain in a patient with a DKA? So CBG should be more than 300 in a child, which means once the CBG goes below 300, you have to start with dextrose infusions in a child. Whereas in an adult patient, the CBG value should be maintained more than 200. In HHS, again the target CBG will be 300 only, 250 to 300 somewhere around. So this is very important. So you have to start with dextrose infusions, and you have to avoid further fall in the glucose resulting in hypoglycemia, because insulin infusion has to be continued. The only way to continue insulin infusions is to add dextrose to the solution, because then only you will have resolution of ketosis, otherwise you won't. Let us see an example now. A case scenario where we'll take our prototype, 80 kilogram man coming with a mild to moderate DKA, which means he's going to have a approximate fluid deficit of 5%, which we have discussed already. So step 1 is over. We have assessed the fluid deficit and we have assessed the dehydration status. And step 2 is to calculate the fluid deficit how much exactly the fluid deficit? It's 4 liters. We have done that already. 80 into 5% is 4 liters. And step 3, you are going to resuscitate the patient. You are going to give the fluid bolus, where in this patient, I'm going to use 15 to 20 ml per kilogram, where I would have given a 1.5 liter bolus. Let us assume with the first bolus itself, he has become volume replenished, and I'm moving on to the step 4. We know already that the step 4 is dedicated for the calculation of corrected serum sodium. So this is very important because this step is the one that's going to determine the type of maintenance fluid that you're going to select, whether it's normal saline or it's half normal saline. So let us assume the corrected serum sodium in our standard guy is normal. So let us assume the corrected serum sodium is 138 milliequivalents per liter, which clearly tells you that your fluid of choice for the maintenance regime is half normal saline, that is 0.45% NaCl. Now you have selected your fluid. Now we go to the step 5. In the step 5, I have to start the maintenance phase. So in the maintenance phase, I have to give the remaining deficit, whatever deficit that is remaining. We know what is the remaining deficit in our guy. It's 2.5 liters. So we have given already 1.5 liters out of 4 liters. So the remaining deficit will be 2.5 liters. Plus I have to give maintenance fluid also. Maintenance fluid we have calculated already, that is 120 ml per hour. So you know the formula for adults. This is an adult patient, isn't it? So 60 ml per hour plus weight minus 20 ml per hour, which roughly for 80 kilogram man it is 120 ml per hour is the maintenance fluid. So let us calculate for the 12 hours. For 12 hours, you will be needing 1440 ml, that is roughly equivalent to 1.5 liters. For 24 hours, it's the double. You will be needing around 3 liters. Why? Because you're going to give in phased fashion, like 12 hours and 24 hours. That's why you calculated now itself. So now, how I'm going to give this maintenance regime is by 2 ways. One, we know the phased regime already, how to give. Let me discuss in detail. But you have another standard regime also. In the standard regime, you're going to give at a standard rate of 4 to 14 ml per kilogram per hour as an infusion in adults. This is applicable only for adults for that matters. And overall, it will come up to 250 to 500 ml per hour as an infusion. This is standard infusion you will be giving for 12 to 24 hours. In a phased manner, which is much better, you distribute the fluids in phase 1 over a period of 12 hours and in phase 2 over the period of next 24 hours. So total of 36 hours. The first 12 hours, you know you're going to give 50% of the remaining deficit. We know the remaining deficit is 2.5 liters and 50% of the remaining deficit is going to be 1.25 liters. Plus, at the same time, you have to give maintenance fluid. But since phase 1 is for 12 hours, what will be the maintenance fluid for 12 hours? We've already calculated. It is 1.5 liters. So I have to use 1.5 liters of maintenance fluid as well. So total it will come up to 2.75 liters, which have to distribute over a period of 12 hours. So once I divide by 12, I'll be getting approximately 200 to 250 ml per hour. This is the maintenance fluid during the phase 1. In phase 2, you know I have to give the remaining deficit, that is 50% still remaining, that is 1.25 liters, plus the maintenance fluid, that is 3 liters, because I'm going to give over a period of 24 hours now. So since I'm giving for 24 hours, I've already calculated that is 3 liters. So total it will be 4.25 liters and it has to be given over a period of 24 hours. So I have to divide by 24, which I'll be roughly getting around 150 to 175 ml per hour. So this is the best maintenance regime. So in a phased manner, phase 1 and phase 2, which I'll be distributing the entire fluid replacement along with maintenance fluid over a period of 24 to 36 hours. By the time the decay would also have been resolved, so there will be no longer there is a need for any maintenance fluid, so the patient can start taking orally. So it's a very excellent regime. So do not forget the step 6, where you have to add dextrose and you have to maintain the target CBG. In adults, the target CBG as far as decay is concerned is 200. In children, it is 300. In HHS patients, it is 250 to 300. You can take 300 as standard. So that you have to add dextrose. Otherwise, giving continuous insulin will produce hypoglycemia. And to ensure continuous insulin infusion without hypoglycemia, you have to add dextrose. Insulin only can resolve the ketoacidosis. That's the reason. So we know how to calculate. We have did an example also. Now let us move on to the treatment with insulin and correction of other electrolytes. Of which, among the other electrolytes, the most important is the potassium. Whether you will give insulin first or potassium first, is dependent on the serum potassium value. If the serum potassium value is less than 3.0, that is 3.2 or less, if this patient is suffering from a hypokalemia and decay indicates a gross potassium loss from the body and a severe potassium loss from the body. So you have to replace potassium first. So you have to hold insulin, do not give insulin in this setting, which would otherwise result in serious hypokalemia and cardiac arrest and death. So don't do that. So hold insulin and you replace potassium by giving potassium at a rate of 20 to 40 milliequivalents per hour. 40 milliequivalents per hour, and start insulin only if the serum potassium is normal. Once serum potassium has become normal, that is more than 3.2, then start insulin. Otherwise, don't do that. And obviously, you have to continue the potassium infusions as well. Suppose if the patient's serum potassium is in the range of 3.3 to 5.2. So this is a normal serum potassium. In this setting, you can give insulin and potassium together. So how much potassium to give? Usually we'll give at a rate of 20 to 30 milliequivalents for every 1 liter of IV fluid that you're going to infuse to the patient. So that is the regime. So 20 to 30 milliequivalents of potassium for every 1 liter of IV fluid that you're going to infuse. And if the potassium is more than 5.2, the patient is having hyperkalemia, in this setting, give insulin only, there is no need for potassium. But at the same time, the patient can later go for rapid intracellular shift causing hypokalemia from hyperkalemic range also. That's also possible. So in that setting, measure the serum potassium very carefully every 2 hourly and take decisions appropriately. Clear? There is no need for giving potassium in this setting if the potassium is more than 5.2. So this is how you replace potassium. At the same time, whether to give insulin first or potassium first or both together depends on the serum potassium. Most of the times your serum potassium will be in the normal range. So which means you have to give insulin potassium together usually. And let's move on to the crux of the DK and HHS treatment that you're waiting for, that is the insulin therapy. How much insulin to give? It depends on whether the affected individual is a child suffering from DK or if it's an adult suffering from DK or HHS. So it's better to use fixed dose insulin infusions both in children as well as adults because FDA has a lot of benefit. It resolves ketoacidosis much faster than the sliding scale that you're going to use. So sliding scale insulin regimen should be strongly discouraged. For example, I have seen a lot of practice setting the infusion rates based on the blood glucose. If it's 200, 250, setting at a rate of 2 units per hour, 250 to 300, setting at a rate of 3 units per hour, 300 to 350 means setting at a rate of 4 units per hour, more than 350 means setting at a rate of 5 units per hour. This is strongly discouraged. Don't keep changing insulin infusion, and this will result in unnecessary confusions and you're going to result in non-resolution of DK. So don't do that. So start with the fixed dose insulin infusion. In a child, usual dose is 0.1 units per kilogram per hour and it will be given as a infusion, and there is no bolus for a child. So in adults, you can use an insulin bolus initially, but in children, there is no bolus, only infusion. So for example, the child is 25 kilogram in weight, you will be starting the infusion rate at 2.5 units per hour. So what you have to do is you have to continue the infusion till the CBG reaches the critical value. So which means you have to maintain the CBG at a target that is more than 300 as far as children is concerned, which we know already. So which means if CBG values are less than 300, once CBG values go below 300 or reach a value of 300, you have to add dextrose solutions to maintain the CBG beyond 300, plus at the same time continue the insulin infusion. Because if you stop insulin infusion, because the fear of hypoglycemia will result in non-resolution of ketoacidosis. So that's not the case. So you have to continue insulin infusion by adding dextrose solutions. In adults, there are many ways to start the insulin infusion. So first, you have a bolus technique where initially you will give 0.2 units per kilogram bolus, followed by infusion of 0.2 units per kilogram per hour. So this is one technique. Second is a no bolus technique. So straight away you can start with infusion like in children, but at a higher dose of 0.14 units per kilogram per hour. So whatever may be the case, you have to wait till you reach the target. So what is the target here? So first you have to know the target fall in the blood glucose. The target fall is approximately 50 to 75 milligrams per deciliter per hour. So this is the target fall in the blood glucose. So if the target fall is not achievable, which means giving at a particular rate of infusion is not causing a sufficient fall in the serum glucose is still high. In this case, you can double the infusion rate. Just you can double the rate of infusion. Still, it will be a FDA only. If you are successful in causing a adequate fall in the serum glucose, then you have to make sure that you maintain the target blood glucose. You should not cause so much fall in the glucose as well. So you have to maintain the target blood glucose in the range of more than 200 if it's an adult patient's DK, or more than 300 if it's a HHS patient, adult and HHS. So which means once your CBG value goes near 200 or goes below 200, we have to add dextrose solutions to avoid further fall in the blood glucose and to prevent hypoglycemia. At the same time, you can continue insulin infusion, but in adults, you can slightly continue at a lower rate if possible. So lower rate in the sense you can half the rate, exactly like 0.02 to 0.05 units per kilogram per hour, which means I'm not asking you to stop the infusion, just reduce the rate once the CBG reaches the target, that is approximately 200 milligrams per deciliter. So continue insulin infusion, but at the same time add dextrose to prevent any potential hypoglycemia from happening. And another very important question that I've been commonly asked is the fact that what kind of insulin that you have to prefer. So obviously in emergency scenarios, I'm not going to use a long-acting insulin. So I'm going to use either a regular insulin or a rapid-acting analog like Lispro, Glulicin or Aspart. But studies have clearly shown regular insulin is the best, because using a rapid-acting analog for IV use is not contraindicated, but using has no significant difference in mortality or morbidity or hospital stay, or even the rapidity of fall of glucose is also not that different compared to that of the regular insulin and the rapid insulin. At the same time, you are going to use a rapid analog at a expense of more cost for the patient. So the cost is also going to be very high, healthcare cost. So don't you do that. So it's better to use a regular insulin itself. There is no need of any rapid-acting analogs in case of hyperglycemic emergencies. Remember, the pharmacokinetic differences in the duration of action and the onset of action for rapid-acting versus regular insulin is only for subcutaneous use. It's not for IV use. For IV use, regular, rapid-acting all behave in the same way only. What about the other electrolytes? Very importantly, we have to know about the bicarbonate, when to replace, especially in the form of soda bicarbonate. Whether you will give or not, remember, usually in DK, even in the presence of severe dose of pH of 7.1 or 7, usage of soda bicarbonate is a big no. You're not going to do that, because in children especially, usage of soda bicarbonate is considered to be a risk factor for development of cerebral edema, which is the most common cause of death in children with DK. So don't do that. So what is the indication? Only two indications. One is pH less than 6.9, more than 6.9, a big no. Second, if the patient is having acidosis along with hyperkalemia, along with cardiac arrest. In this condition, you can use soda bicarbonate. That is to combat the acidosis and hyperkalemia and cardiac arrest, not for the purpose of DK itself. So these are the only two indications that you are going to give soda bicarbonate. Otherwise, no. What is the dose of soda bicarbonate that you're going to give? It is usually 100 milliequivalents of soda bicarbonate, and you're going to mix in 400 ml of water. Remember, already soda bicarbonate contains sodium, so it's not a problem. You need not add in sodium containing solutions. You can just add in water, not a problem. So, and this has to be infused over 2 hours. At the same time, please add 20 milliequivalents of potassium as well. So why I'm going to add 20 milligrams of potassium? Because correcting acidosis with soda bicarbonate is going to cause more intracellular shift of potassium. So that's the reason why I'm going to add potassium chloride to the solution as well. So what will be the target? So by giving this, my target pH should be more than 7. So if my target pH is less than 7, then I can repeat the soda bicarbonate again, one more time. Similarly, there is a concept called as bicarbonate deficit. Bicarbonate deficit. How do you calculate the bicarbonate deficit? It is done by a formula called 0.5 multiplied by body weight multiplied by 24 minus actual serum bicarbonate. So this will give you the bicarbonate deficit. For example, a 60 kilogram man who is having a serum bicarbonate of 14. If they ask you what is the bicarbonate deficit, I'll be simply calculating 0.5 into 60 multiplied by 24 minus 14, that is 10. So it will be equivalent to 30 multiplied by 10, that is 300 milliequivalents will be the bicarbonate deficit in this individual. This is how you calculate the bicarbonate deficit. Similarly, there is another formula using base deficit where you use a formula of 0.3 multiplied by body weight multiplied by 24 minus the present serum bicarbonate. But here you have to multiply with base deficit as well. Base deficit as well. Clear? So this is also another approved formula for finding out the bicarbonate deficit. But we don't use all these formulas in the setting of DK. In general, we use a common dose, that is 100 milliequivalents of soda bicarbonate mixed in 400 ml of water along with 20 milliequivalents of KCl, and it has to be infused over 2 hours, and the target pH should be more than 7. If it is not achieved, you can repeat the dose one more time, no problem. And the next electrolyte that you have to discuss is about the phosphate replacement. Whether it is necessary or not, routinely it is not at all necessary because most of the hypophosphatemias are asymptomatic in DK patients. So suppose if the phosphate is extremely low with a value of less than 1, in this setting you can replace the phosphate in the form of potassium phosphate available in many tertiary centers, because such very low phosphates are having a high risk of development of rhabdomyolysis, especially in children with DK, which is very important. So now let us move on to the complications. The number one complication, the most common complication is going to be persistent acidosis, persistent low pH, persistent low bicarbonate. So what are the reasons for persistent acidosis? The first reason is hyperchloremic acidosis, which is supposed to be the most common reason. Usually it's a very benign thing. It is due to excessive infusion of sodium chloride based solutions, which is actually evident by elevated urinary chloride. And it's a self-limiting and a benign condition. No need to do anything for that. So it could be a persistent ketoacidosis, which is not a very good sign because you are not giving insulin adequately. Or it could be sepsis as well, causing a lactic acidosis. So you have to differentiate these causes. So whenever a child with DK or an adult with DK is having a persistent acidosis that is not resolving beyond 24 hours, then you have to see the ketones first, beta-hydroxybutyrate first. So if the ketones are more than 1.5 or less than 0.6, which means ketones are still elevated or it is resolved. So if the ketones are still elevated, which means it's persistent ketoacidosis, which clearly means your insulin therapy is inadequate and you have to add more insulin and you have to give a proper insulin regime. So which means you're doing something wrong, like sliding scale or not giving adequate insulin dose. So that is the reason. If the plasma beta-hydroxybutyrate is less than 0.6, which means the DK has resolved in that setting. So what is the reason for acidosis? So you have to see the anion gap in that setting. The anion gap is more than 12 or if the anion gap is less than 12. If it's more than 12, I'm dealing with a high anion gap metabolic acidosis. If it's less than 12, I'm dealing with a NAGMA, that is normal anion gap metabolic acidosis. Usually, high anion gap metabolic acidosis in the setting of resolved ketoacidosis usually will be due to sepsis, which can be further confirmed by doing a serum lactate, which will be usually elevated in this setting. So in this setting, my treatment will be with aggressive antibiotic therapy. Along with that, I'll be giving IV fluids and vasopressors, if possible inotropes if it's a severe sepsis. So if it's a NAGMA, very commonly it will be a hyperchloremic metabolic acidosis, and this can be confirmed by seeing the urinary chloride, which will be elevated. So the treatment is nothing. Usually it's a self-limiting benign condition. So no need to do anything. It will automatically resolve on itself. So this is how you are going to approach a diabetic ketoacidosis patient who is going to have a persistent acidosis. Obviously, the next most important and dangerous complication is going to be the cerebral edema. And please remember the fact that cerebral edema is the most common cause of death in children who are suffering from DK. Having said the word children, that is true because adults with DK very rarely get cerebral edema, which means DK usually do not result in cerebral edema if the patient's age is more than 20 years. So it's a very important complication in children, not in adults. And there are multiple risk factors which we'll be discussing subsequently. And cerebral edema usually happens after starting therapy, like after 12 hours, very, very commonly. That is the time where cerebral edema sets in patients with DKA. But it can happen anywhere around 6 to 24 hours, and you have to be very, very careful during that time. So we have to carefully observe the child for the signs of development of cerebral edema. And what is the mechanism behind this development of cerebral edema? The first mechanism is vasogenic mechanism, or called as vasogenic theory for development of cerebral edema in DKA, which states that in children especially, the vessels will be oversensitive to changes in the carbon dioxide. So these patients are going to have hyperventilation that is due to the acidosis that they are encountering. And this hyperventilation is going to reduce the PaCO2 drastically, especially PaCO2 values of less than 20 is going to have a higher risk. And since the brain vessels in children are more sensitive to change the PaCO2, this low PaCO2 is going to induce vasospasm, which will result in cerebral hypoxia and subsequent edema. So this is the mechanism behind development of cerebral edema in children, and this has a substantial amount of evidence experimentally as well. Apart from that, the osmolar theory is the one that is widely accepted and supposed to be the most common mechanism for development of cerebral edema in children. That is due to sudden shift in osmolar forces. Typically that happens around 12 hours, after 12 hours, but it can happen any time during 6 to 24 hours after initiating treatment. So that is the reason why this period you have to carefully observe the child for any changes in the mental status or declining Glasgow Coma Scale score. All these things are very, very important in detecting cerebral edema in children. So how this osmolar forces shift is going to result in cerebral edema. We know that already, but let us see through an example. So we know that initially there will be hyperosmolarity due to excessive glucose, and the cell adapts to this hyperosmolarity by producing this extra osmoles in the form of taurine and myoinositol, and this is what we refer to as cellular adaptation. That is to prevent further shrinkage and movement of the water out of the cell. So what you are doing during treatment is giving insulin. At the same time, you are going to give potassium as well. So what this is going to do is the fact that it's going to push the glucose into the cell. Number one, already the cell is having excessive osmoles and you're not giving any time, and suddenly you're pushing the glucose molecules into the cell. At the same time, you're going to push the potassium molecules also into the cell. Remember, potassium is as osmotically active as sodium. So once potassium goes into the cell and glucose moves into the cell, and already there is a lot of osmoles inside, so that is going to result in more and more osmolar forces within the cell. And coupled with that, because you are shifting the glucose and potassium here and there, but it's not staying in the extracellular compartment, and there is a dramatic decline in the extracellular osmolality or extracellular fluid osmolality. So obviously now fluid will start moving from a region of lower osmolality to a region of higher osmolality. Now there will be a rapid fluid shift that will happen into the cell, resulting in the development of cerebral edema. So this is the osmolar theory, and this is very, very important to understand. So that is due to rapid shift in the osmolar forces. So what are the risk factors for development of cerebral edema in DKA patients? The first risk factor is the age itself. If the child is less than 5 years of age, just because they present very late, delayed presentation, they are going to have a high risk of development of cerebral edema. And severity is a very important issue. Severe DKA patients are more prone. Sick looking child, very ill looking child, high risk of development of cerebral edema. And failure of serum sodium to rise. This is a very important factor that results in cerebral edema. We know very well that with treatment, not only the glucose should fall, the serum sodium also should rise. So we have a relationship, glucose rising and sodium falling, and this is very important for maintaining the serum osmolality in an OK level. I told you already. But if you start the treatment, the glucose will automatically fall, and at the same time, the serum sodium should automatically rise because it's a false hyponatremia. But if the serum sodium is not rising and it is persistently low despite reducing this glucose means there will be a gross fall in the serum osmolality. Now the serum osmolality will fall because there are two counteracting forces. One has given up and the other has not, which means that will move towards that side. So serum osmolality will obviously fall. So that sudden change in the serum osmolality because of failure of rise of serum sodium, but the glucose has fallen, is important for the fluid shift from ECF to ICF, resulting in cerebral edema. And the usual reason for the failure of serum sodium to rise is SADH causing dilutional hyponatremia, because SADH is a common AD because of the underlying problems that these children and adults are going to have. Because the infection can precipitate development of SADH. Any injury to the body can precipitate development of SADH. So that's the usual reason. And number 4, in very severe hypocapnia, if the PaCO2 levels are very low, that if it is less than 20 millimeters of mercury by vasogenic hypothesis, definitely this should be a risk factor for development of cerebral edema. And aggressive fluid resuscitation is a very controversial entity, but still it's thought to produce cerebral edema. But many researchers do not agree to this. They believe that already the child has been predisposed to development of cerebral edema, but aggressive fluid intake or aggressive fluid resuscitation is only an associated factor, not a real risk factor. But anyway, it's controversial. We need not go into the controversy. Just it's a risk factor. That much you have to understand. And soda bicarbonate treatment has been linked to development of cerebral edema. That is the reason why currently soda bicarbonate is indicated only in very, very compelling indications, like if they have very severe acidosis like pH of less than 6.9, or if the patient is having life-threatening scenarios like acidosis, hyperkalemia, and cardiac arrest. In those settings, you can use soda bicarbonate, otherwise you don't give. Apart from that, how we are going to identify these patients? Because clinical identification is very important. The first one is the declining GCS, which may manifest as altered mental status, or even the child may go for posturing. Very, very important. And at the same time, patients may have plantar extensor Babinski positivity, and at the same time, patients go for generalized weakness, and at the same time, patients may develop focal neurological deficits like cranial palsies, which are relatively early and common. Like they develop paralysis of cranial nerve 3, 4, and 6 in isolation or in combination. For identifying DK patients clinically who are going for cerebral edema, Muir and his colleagues has given a diagnostic criteria for the detection of cerebral edema in DK patients, especially in children. So in that, altered respiration, Cheyne-Stokes breathing, all these things will come into play, because your Cushing's triad is also very important, which tells you that's a raised ICP, like your increasing BP, reducing pulse rate, that is bradycardia, and if the patient is having altered respiration, irregular variable respiration like Cheyne-Stokes breathing, all these things will come under Cushing's triad of raised ICP, and all these things has been integrated in this chart given by Muir and his colleagues for the detection of cerebral edema in DK patients. But one important point that you have to understand is the fact signs that occur before the treatment should not be considered in the diagnosis of cerebral edema, which means the child is having a neurological deficit before starting the treatment, before coming to the hospital, that should not be included in the clinical examination point while making a diagnosis of cerebral edema. And will you do any investigations? You can do investigations. I'm not telling you should not do investigations, but do not wait for the investigations like CT or MRI, and start with the treatment as soon as possible. So do not delay the treatment. You're going to treat immediately with mannitol 0.5 to 1 gram per kilogram. Very, very important. Otherwise, you're going to result in devastating consequences, and it's going to have a poor prognosis if you treat late. At the same time, you have to reduce the IV fluids by a tune of 60%. So these are the treatment options available for cerebral edema in patients with diabetic ketoacidosis. And you have some other complications that can happen in patients with DK and sometimes with HHS. That is hypokalemia, persistent hyponatremia because of syndrome of inappropriate antidiuresis, that is SADH, or they can develop rhabdomyolysis very rarely. That is because of severe hypophosphatemia most often. And they can also develop renal failure. Usually it will be pre-renal in nature because of the hypovolemia. Once it's corrected, it will settle usually, but that's a transient complication only. And they can very rarely develop arrhythmias because of acidosis and hypokalemia. But these are rare complications. Very common are the persistent acidosis, which is extremely common, and second is the cerebral edema, especially in children. Now finally, the last question is when to stop insulin infusion. That's again a $1 million question. And when to transition these patients towards subcutaneous insulin. When will you do that? It's quite simple. First, you have to resolve the ketoacidosis. DK should be resolved. That's the indication to stop the insulin infusion. Or in HHS, you have a separate indication, which I'll tell you. In DK, when to stop. So first is you have to resolve the ketoacidosis. Then only you can stop the insulin infusion. So for that, first thing, anion gap should be less than 12, or your beta-hydroxybutyrate value should be less than 1 millimoles per liter or vaguely less than 10 milligrams per deciliter. Second, your acidosis should be resolved. Not only the ketosis, acidosis also should be resolved. pH should be more than 7.3 or equivalent serum bicarbonate should be more than 15. If you do venous pH and venous bicarbonate, it's more than enough. No need to do an ABG. And third, the patient should be tolerating oral feeds. Then you can start with subcutaneous insulin. Otherwise, you have to continue the insulin infusion along with dextrose to prevent hypoglycemia. Fourth one, plus or minus. Not a very important thing, that is the blood glucose. This is not important at all to stop insulin infusion. Blood glucose is only optional thing. If it is less than 200 milligrams per deciliter, you can transition to subcutaneous insulin. And in HHS, there are some criteria to stop insulin infusion, like if your serum osmolality becomes less than 315 milliosmoles per kilogram, and if the patient becomes mentally alert and he or she is able to eat because they are mentally alert. So these are the indications to stop infusion in HHS. Once these are satisfied, in DK the first three are the most important. So once these indications are satisfied, now you can make a transition to subcutaneous insulin. But please understand the fact, one small caveat is there. Even though you have injected the first dose of subcutaneous insulin, still you have to continue the infusion for 2 to 4 hours. That is because this subcutaneous insulin takes some time to act, and to prevent the rebound hyperglycemia, you have to maintain the infusion for 2 to 4 hours even after giving the first shot of subcutaneous insulin. So that's an important point. So now the question comes, how much of subcutaneous insulin has to be given? How much dose? So for that, you have to ask the question whether the patient has been taking any insulin in the past or not. So that's what the question I'm going to ask, whether the patient is insulin naive or not. If the patient is insulin naive, which means they have not taken any form of insulin in the past, then usual starting dose is 0.5 to 0.8 units per kilogram, the setting of DK. In that, you will split into 50% and 50%. So 0.5 to 0.8 units per kilogram will be the total daily dosing of insulin. That's called TDD. In that, you will split into 50 and 50. 50% will be given to basal shots. So basal insulin can be either a long-acting insulin or a intermittent-acting insulin. Long-acting insulin, very commonly what we prefer is glargine once a day, or you can use NPH twice a day. Glargine is once a day. Glargine, NPH has to be given twice a day. So the entire 50% of the total daily dose will be given as OD if it's a glargine. But it has to be split into 2 doses if it's going to be a NPH. So how you are going to split? You are going to give 2/3 in the morning and 1/3 in the evening. So that's how you're going to give. As per the NPH rule, the patient should take a midday snack, and that is very important because of the risk of hypoglycemia, because of the distinct peak caused by NPH we have already discussed in the previous chapters. And then, what about the rapid acting analogs? So remaining 50% should be bolus insulins. And this bolus insulins, very commonly we start with rapid acting insulins. Especially in children, rapid acting insulins are the gold standard right now. You can start with Lispro, Glulicin or Aspart. So how much you are going to give? You are going to divide according to the meals. This 50%, if the child is taking 2 meals, divide into 2 times. The child is taking 3 meals, divide into 3 times. The child is taking 4 meals, divide into 4 times. So divide according to number of meals. That's all. And let us see this as an example as usual. So let us take a 60 kilogram man who's being transitioned to a subcutaneous insulin. So in this setting, first you have to calculate the TDD. So let us take 0.5 units per kilogram to start with, the basic calculation. So the TDD will be automatically 30 units. So 30 units will be the requirement in this patient to start with. And this 30 units, I know 50% I have to give as a basal dose, which will be 15 units. And remaining 50% I have to be giving as bolus dose, which comes to another 15 unit. And the basal, I can either give a long-acting insulin like Largin, which will be given as a once daily formulation. So in this setting, I'll be using the entire 15 units as once daily dose. Or alternatively, I can use NPH as well, but NPH has to be given in twice a day dosing. In this setting, I'll be giving 10 units, that is 2/3 of the 15 units in the morning, and remaining 5 units in the 15 units in the evening, that is 1/3. So that's the basic idea. Now, bolus insulin, the usual insulin I'll be preferring is either regular insulin, or very commonly, we are going to prefer rapid acting analogs like Lispro, Aspart, or Glulisin. Let us use Glulisin for that matter. So let us assume the patient is taking 3 meals, and I'm going to split that 15 units into 3 different meals, like 5 units, 5 units, and 5 units before each meal. For example, I'm preferring a Glulisin as a bolus insulin here. That's all. Suppose if the patient is insulin user already, which means the patient is not insulin naive and has been using insulin already. In this setting, there are some complicated calculations are there. For that matters, you can take the last 6 hours of insulin dose that was required during the phase 1 of the maintenance phase, the maintenance fluid phase, phase 1. The last 6 hours of the insulin dose may be calculated, and you can use that dose to give the basal insulin. And you will usually reduce by 20% in case of risk of hypoglycemia. But anyways, that is some calculations there. But those kind of complicated calculations has been removed currently from the guidelines. And what they are currently telling is you can just continue with the previous insulin dose. If they are taking insulin pumps, then also it's fine. You can continue with the same dose of insulin, and then you can titrate based on the response and the glycemic index of the foods they are taking. So that's all. So this is how we are going to transition to the subcutaneous insulin. So with this, I think we are completing a huge chapter on hyperglycemic emergencies, which is very, very important for your exams as well as for your practice. And let us move on to the next chapter on ambulatory care of type 1 diabetes mellitus.